We're live.
Welcome back, folks. This is Joint Justice Site Committee, or 1 o'clock. So we're here for our afternoon meeting. It is Tuesday, November 28th. And we're going to start off the afternoon with getting some background information on a bill that passed. We have a House Human Services Committee and did pass and was signed into law. It is now Act 22. It was H222, and it's relating to reducing overdoses. Katie McClin was going to be here to give us a walkthrough. She's unable to be here today. So we're going to have a tag team with Ben and Teresa Wood that came out of Teresa's committee.
Went through ours too.
Yes, there's two.
There you go.
So we'll have a tag team with you three to kind of give us a walkthrough quickly of what the law says, and then we've got some folks who are going to have some testimony from.
Well, Ben Omegrowski, for the record, from the Office of Legislative Counsel. I think a good place to start is what the charge of the committee is. So in Section 8 of Act 22, it authorized the committee to provide recommendations to House Human Services and Senate Health and Welfare regarding any legislative action needed to ensure continuity of treatment for individuals re-entering the community after discharge from a correctional setting, including eliminating prior authorization for medication for opioid use disorder. So that's what the committee is looking at today, and providing potential recommendations along those lines.
What section was that again? I'm sorry.
Section 8.
Thank you.
Yeah, there is a document from Katie McClin there, but it only includes the last two sentences of Section 8.
Oh, okay.
It starts off with 8A. So it doesn't include our charge.
I'm looking at the full bill on the side.
Right, but the document that's on our committee webpage right now.
8A and B. Did I miss?
There's page 12 would have the charge.
Oh, I apologize. I did 13 and 14. I didn't realize.
It's okay.
That's fine.
Bill's easy enough to find.
Sorry about that. Sorry.
So I thought maybe between Senator Lyons and myself, we could give a little bit of background about how this came about. So Act 22, convenient, since it was H222, you know, keep it all in twos. It's the only way I can remember Act numbers, because I'm always remembering the bill numbers, not the Act numbers. So Act 22 or H222 really was the body's, I guess what I would call omnibus overdose prevention bill last year. It addressed a number of different areas that we heard about in testimony, everything from community response around needle disposal to recommendations from the opioid overdose committee. And one of those things that came up during testimony is the differences between the medication-assisted treatment in correctional facilities and the medication-assisted treatment in the community. And those differences have resulted in some negative outcomes for people who have left the correctional facility, up to and including death. And that includes not only the differences in the type of medication, but at least at one point in time in the delays that are encountered in people being able to receive the medication-assisted treatment once they leave the correctional facility. And we have heard references in this committee earlier this summer, a little bit to this. I don't remember if it was Commissioner Demmel or somebody else, but and I think that we'll hear today about, you know, some potential improvements to the system that in terms of the discharge planning. I think that's how we were looking at it earlier this session in terms of discharge planning. So the body, when we passed this bill, really asked this committee to take a closer look at really essentially what can be done to assure that there is the smoothest transition possible between leaving an incarcerated setting and being in the community setting, because absence of medication-assisted treatment does result in cravings for the substance and, the person, essentially doing whatever they can to obtain the substance, and then in a number of cases overdosing, and in some cases has resulted in death of people who had left incarceration relatively recently. So that's why we felt it was important to include in this bill, important to have some further testimony on this, and to look at any recommendations that this committee might make. Senator Lyon, do you have anything you want to add to
You've
that?
done a good job of going through the bill. There were some differences between the House and Senate versions of the bill, which were, we went back and forth and were resolved. I think it's important to understand that we're trying to understand how best to treat folks with substance use disorder at any stage of whether they're incarcerated or out of incarceration and transitioning out into the community. And so part of this is part and parcel with the discussions that we've been having in here. And then further, this discussion that we will have, I think, will be very helpful in understanding what we can and what we cannot do in terms of the gold card for prior authorization. I think the commissioner of DEVA will be talking about that. And then some of the other nuance of what we can and cannot do when people are under in the corrections environment or out of the corrections environment. So our job here.
Mm-hmm.
But this is an important bill for substance use disorder generally, and it linked in with some of the funding pieces and funding stream that we looked at in the bill that we put in place for the opioid settlement process. Mm-hmm. So, and then that continues, that's continuing on. So we're going to see more as we go forward. I don't have much more to say.
I think we recognize that it's a particularly vulnerable point in a person's life when they're leaving incarceration and returning to the community. And if there are things that we can do to reduce that vulnerability, then that's, what we would like to do. I think that's all I have in terms of background. If anybody has any questions about.
So the two things that I picked up in terms of, it was when we put in the MAT program in corrections, came out of Corrections and Institutions Committee, we were very clear that the MAT program that would be offered in corrections was no different than the MAT program that's offered in the community. We didn't want anything less, and we didn't want anything more. And we were very clear about that. We're clear about that, and all the testimony we received, and when we put in the statute that initiated the MAT program. So what I'm hearing is that there is a difference. And I'd like to know a little bit more what that difference is. I mean, one thing is there's a different type of med that's used in the incarcerated setting. And part of that is because of the cost, from my understanding, is it's not a strip, it's a tablet. And then when the person reenters the community, they need to get to the strip. And there's a lag there. And part of that is from testimony we've also received previously about the availability of healthcare coverage and being able to qualify and sign up for Medicaid. So there's a lag there. Is there any other difference from MAT that's being operating in the incarcerated setting versus what's happening in the community?
I think you've summarized it well, and we will hear from the experts about their experiences and what is current right now, which I think is important. I think that the impact in terms of what was originally intended was achieved, in terms of the MAT in the incarcerative setting being comparable to the availability. But there are those which seem like minor differences, but don't end up being minor. And I think that's what our experience has shown us, and what testimony in my committee has shown us, is that they don't end up being minor differences.
So does Act 22 go to address those differences?
It does not. It says, this committee, please take a look at it and make recommendations back, which is what we typically do. Essentially it was one of those things where we ran out of time, but knew was an issue, and we didn't want it to get lost.
Senator Sears, and then go to Keisha.
I think it's important that we hear from corrections at our next meeting before we take further action on this. But my understanding was, and maybe Diva can help us with this, is that there is a federal program that enables you to go from incarcerated setting where there is no Medicaid to a non-incarcerated setting, and so that it can be seamless. Now, I've heard that through CSG Justice Center, and if we have to check with them between now and the next meeting, we can. But I think that's a real critical point where people sometimes lose the services. And as Representative Wood mentioned, that we've had overdoses and deaths resulting from many of those lack of continuity between the two. But I really think we have to hear from corrections before I'm ready to make recommendations on any changes. And it's unfortunate that, well, it's not unfortunate. Congratulations to Commissioner Demmel on the birth of a new child and all that. But I believe he'll be back before the December 12th meeting. And I think it would be good if Isaac can get to him and make sure he's prepared to talk about that issue.
Yeah, we were hoping to schedule some DOC today, and the commissioner's unavailable until we have our meeting on the 12th.
Yeah, I mean, this might be something that's just so obvious to the committees of jurisdiction that it goes unsaid, but, when you're on the committee that deals with housing and peripherally transportation, that proximity issue is, I think, one of the biggest. And I just haven't heard lately philosophically from the relevant departments or committees, like where we are philosophically with proximity. And what I mean by that is a lot of the best MAT programs globally are like mobile and go right to where people need it, or, people are starting to look at overdose prevention facilities where there's no barrier to walking in and getting help.
So one section of the bill does allow for recovery residences to be considered appropriate single family, up to 8 folks.
Okay.
Single family homes for purposes of exactly what you're saying.
Right. And just people who don't have a home, can they go to the pods?
So this would allow for those residential uses of property and allow for people to.
Oh, I see.
There in local communities.
Okay.
Yeah.
I think it does speak to what exactly is the transition process. So, our people, so for instance, if you go to an emergency room and with the overdose, and you leave in most emergency rooms now with 3 days supply and an appointment to hook you up, and so it will be helpful for us to hear more about what's the transition process between the discharge planning process for somebody leaving to assure that they have proximity to that. And we did have a situation where we didn't have sufficient hub and spoke access, and it definitely has expanded, but is that sufficient yet? So it's kind of all of those things wrapped up into it. But this particular question is really about the discharge planning process and the access to a similar medication and similar, I guess, ongoing, hooking you up on the ongoing basis with what you will need if you're in the community, when you're in the community, so.
I'm going to go to Topper first and then Senator Sears.
Thank you. If you explain what the role of the healthcare provider is going to be in this, I see one sentence there with 90% of the prior authorization requests submitted. What is the role of the healthcare provider when the transition takes place from the institution out into one of these homes or to their own home?
Yeah, I was going to say, I think it might be helpful to hear from our witnesses that might help start to answer some of those questions, Representative McFawn. And perhaps we could hear also from at our next meeting when Commissioner of Corrections is here, we might want to hear from the Commissioner of Health as well with regard to what they believe the access is.
Senator Sears?
Since Representative Wood brought it up, as many of you may know, Bennington lacks a methadone clinic and has for a long time. And we have a site, we have a provider. Department of Health has been great, but now the Green Mountain Care Board is requiring a CON process, which is holding up the entire bailiwick. And I would like to, this is not really necessarily justice oversight, except that many of the people are corrections people who have to go to North Adams, Mass, or Brattleboro, or even Greenfield, Mass. So it is a problem in terms of transitioning, and whether or not maybe the Department of Health can speak to how we can legislatively not have this part of the CON process.
I think that speaks to what Senator Rumpensdale was just talking about. Yes, as well, Senator Sears, in terms of proximity and access. Is there? We can have a process, but if the individual doesn't have access because of their proximity or where they are living, if that all becomes part of the problem. Yeah.
Yeah, because I remember when we began methadone clinics, there were folks driving 2 and 3 hours twice a day to get their methadone. And then we expanded the clinics. And now we're looking at where we need to expand them further and what other medications should be available to help folks as they are treating themselves for recovery. It's really about a recovery process. So we don't want to just link it to the drug that's being taken, but rather to the full process of recovery. And that's why.
I totally agree. And I think we should talk about access and how we can make that access easier. And the CON, certainly for something of this nature, doesn't exactly provide a lot of quick solutions.
Yes, you're right.
So, Ben, do you have anything you want to weigh in? Because I know you're filling in on this for Katie.
Yeah, I mean,
Then we'll.
not necessarily from a background perspective on the bill itself. I mean, I would just actually on that, I would just say that the bill itself was really about outside of the facilities. It didn't talk about those differences that it's meant to be for today. But I do think it's important to know sort of the right now correctional facilities under 28 VSA 801B. That's what governs medication assisted treatment in those facilities. And specifically in subsection B, it discusses as part of reentry planning, the department shall commence MAT prior to inmates' release if they meet 3 conditions. 1, the inmate screens positive for an opioid use disorder. 2, medication assisted treatment is medically necessary. And 3, the inmate elects to commence the MAT program as well. And then if medication assisted treatment is indicated and despite the best efforts of induction is not possible prior to release, the department is responsible to ensure comprehensive care coordination with a community-based provider. So that's in statute what the reentry portion of this is. And this was part of a broader act in, I think it was Act 176 in 2018 that really outlined the medication assisted treatment program coming in and during a stay at a correctional facility. And then subsection D is what outlines the reentry portion, at least by statute, not necessarily by policy or procedure.
So we have with us the Commissioner of the Department of Vermont Health and Access. The Department of Health here, so we'll make a note of that in Department of Health. At our December 12th meeting, as well as the Commissioner of DOC, but we do have Andrea, and I'm gonna botch your last name, I'm not even gonna try it. So we have the Commissioner of DEVA with us, so welcome. And if you could identify yourself for the record.
Absolutely. Thank you, Madam Chair, and thank you for having me today. For the record, Andrea DeLabriere, Commissioner of the Department of Vermont Health Access.
Welcome. So you've heard some of our conversations here, so please weigh in.
I have, and as I was sitting here, I was thinking I really wish the Department of Corrections was here right now. As the Medicaid program, I can speak to those components. I can speak to my limited knowledge of the Department of Corrections process for community reentry for folks that have been incarcerated. But they really, again, you all know that they're the experts on this topic in terms of what happens in the transition. But that is also my understanding is that they coordinate with community providers upon reentry into the community. I'm not sure exactly where you would like me to start. I have a few data points I can share with you. But what would be your preference in terms of how you want to navigate this topic, complex as it is?
Well, we're open. I think we really like more to focus in on, and I know DOC isn't here, but I think we'd like to focus in on that transition from DOC to the community.
Okay. I'm happy to try to
help us in some way with that. And then I'm going to defer to both Representative Wood and Senator Lyons as chair of those respective committees.
Okay. That sounds great. So I can share with you, and this came from the Department of Corrections, so I feel confident that it's accurate. The discharge process for folks that are incarcerated and then exiting into or re-entering the community, they are given a prescription if they are eligible and on MAT treatment for Suboxone when they leave incarceration. And that's my understanding is everyone receives that. In addition to being given that prescription for it's 3 to 7 days is my understanding. But again, please confirm this with the experts. Prior to being given that, the Department of Corrections contractor, which is now, I believe, WellPath, they coordinate follow-up appointments for the individual with community providers. That's their role. And then Medicaid's role in the discharge planning process is to ensure that folks leaving incarceration get the eligibility pieces in place for them to enroll in Medicaid. And so we work very closely with the department to ensure that as best we can. I'm sure that there are areas where we're not 100%. But ensure that there aren't any failures in folks being enrolled in Medicaid if they're eligible. And we do that in conjunction with the DOC very closely. Does that help?
That helps, okay. But so DOC gives the person a prescription for Suboxone.
Correct.
And it's a 3 to 7 day prescription.
Correct.
So the person that's reentering goes to a local pharmacy with a prescription in hand, would they be able to walk out that same day with that prescription being filled, or do they have to wait for insurance coverage from Medicaid?
So if they're actively enrolled in Medicaid, there wouldn't be a delay. But I understand your point. If there's a gap and they're not actively enrolled, then it is the time frame where they leave incarceration, determine eligibility, and then become enrolled. That could potentially be a gap. I don't know off the top of my head how often we've seen that happen. I think most folks do become eligible for Medicaid or have already been actively engaged in Medicaid, but I'd have to do some research on that piece. We are exploring we're exploring two avenues. One is more days of prescription medication as folks leave incarceration. We are not exploring that. The Department of Correction is exploring that. Medicaid is exploring the opportunity through the waiver, through the 1115 waiver, to offer Medicaid services prior to release. And that is an opportunity that I believe California is currently taking advantage of, but we are a little bit of ways away from that. And we're anticipating to begin negotiations in the late winter, early spring, just based on the time frame.
That one's more complicated.
Yeah.
The waiver is
waiver,
really complicated.
But we've been, Commissioner, the time frame for folks who are being released, we had talked about a 30-day period of treatment prior to being released. Is that what will be in the waiver? Because we've been talking about this for a while now.
Yes, that is the opportunity, Senator Lyons, and it is, I believe it's 90 days.
Yeah, 90.
Okay, so 90 days.
Yes, and that is part of CMS needs to approve it. There's a whole, as you know, there's a whole complicated process, but we are exploring that, and it makes a lot of sense. But again, it's how is that paid for? How is the waiver opportunity implemented in CMS?
Just as point of information, in California's waiver, what's the match, the state match for that? I know we have a pretty good match for our state federal, and I'm wondering, we'll be able to keep that same level of 4757?
I'll have to get back to you on that. I don't have that handy, sorry.
Thank you, Commissioner, for being here this afternoon. I think, and I don't know, to ask this of corrections or to ask this of you, but it would be helpful if we could have the data on the number or percentage of individuals who actually leave the correctional facility with their Medicaid reinstated or instated initially, if they didn't previously have it.
Okay.
So we can know, are we talking about, 1%? Are we talking about 10%? And is there any possibility on a policy level of a presumptive eligibility for somebody leaving an incarcerative setting for a period of time? I'm not saying indefinitely, but, I guess I'm making some certain assumptions about somebody who's been in an incarcerative setting for some period of time. And it seems as though there's some logic to having a presumptive eligibility for Medicaid that might be easier to implement, and then have that process, where you're looking at, all the things that you have to look at, happen within, 30, 60, 90 days or something like that. Is there any ability to take a look at something like that?
I think it's worth exploring, Representative Wood. I know we've done a bit of this exploration with long-term care and eligibility with long-term care. And so I don't know, I know presumptive eligibility is tricky for a number of reasons, but let me just explore that with the team a little deeper, because I think they're the subject matter experts, and I think it's worth a look.
Sure, I
At least
appreciate
in the
that.
interim, until we have a new waiver opportunity, if that comes to fruition.
Right, and that's, I guess that's what I am wondering about, because even though we, it's, as Mr. Novogrodsky told us, there is a requirement in statute for certain things, but we know for any variety of reasons that it doesn't always happen that way. And it's just such a particularly vulnerable time that, and we have had examples of loss of life as a result of this. So it seems like we know enough to know that there are times that it doesn't work and that we need to have some kind of solution, whether it be a temporary solution or, while something else is being worked out, like, through the 1115. So I appreciate you taking a look at that. And like I said, I wouldn't be looking, or me personally, maybe somebody else would be, but wouldn't be looking for, presumptive eligibility, to last indefinitely, but that would enable the engagement of the individual once they're in the community to, provide whatever information they need to provide in order to, get signed up for Medicaid on an ongoing basis. So I appreciate you taking a look at that. And I don't know if it's possible, but reporting back at our December 12th, is that the date? 12th meeting? At least, well, at least giving us some idea about whether we could have the ability to pursue that or not.
I think that's fair. I can do that. I think it also might be worthwhile, let me know your thoughts about this, but to provide some data on how long it takes. If someone, for example, is not necessarily enrolled in Medicaid prior to incarceration and they're reentering the community, how long does it take that individual to become enrolled? Would that be helpful?
Yes, for sure.
So I also have a question in terms of how do we know if WellPath is coordinating the follow-up appointments with a provider?
That's that's a quality control issue with
That's a real
DOC.
well, also, a lot of folks who are incarcerated do not have a provider on the outside.
Right.
So if you don't have a provider on the outside, who's there to hook up the person with a provider?
If a provider
Is available. That's one piece that really comes into play. And the other, and I'm going to ask corrections this, do folks who are incarcerated get Suboxone as well? It's just in a different form.
Subutex, which
It's
is the mono
Subutex.
product, just
And that's because they're in a tablet, not a strip. If they get the strip, it would be the Suboxone.
and Suboxone includes naloxone. It's naloxone and buprenorphine. And Suboxone is the brand name.
And the tablet that we get, does that also include the naloxone?
It's the mono product, so just buprenorphine.
Just
And
buprenorphine?
currently, although we're evaluating that,
And it's the cost
these folks are not eligible for Medicaid. That's
when they're incarcerated,
That's
right? There's no
yeah.
insurance.
But, obviously, if we can get approval from CMS to have a transition process that enables them to be enrolled in Medicaid while in the correctional facility, whatever it is, 30, 60, 90 days before discharge, then one, there could be a transition to that different medication. I think an easier facilitation to a provider, even though it's not easy, I know that, but it's easier if you can say at least you have insurance.
Right. The other thing too, beyond the 1115 waiver, isn't there also a bill going through Congress, if it can ever get through Congress, that deals, that would allow a 30-day window for signing up for Medicaid or at least getting, it seems like that was testimony we've heard along the way.
I think you're right, yeah.
I
There's
think
a,
that's true.
Yeah.
I think that's true. I sometimes conflate the two, because there's a 30-day conversation and a 90-day conversation.
Yes, that would be the Reentry Act of 2023, which is on the Senate side is sponsored by Senator Tammy Baldwin, and our delegation has co-sponsored that bill.
And that's a 30-day that would allow Medicaid,
Yes.
if Congress could ever get their act together. Something
Yeah,
to grow.
wouldn't count on it.
Yeah. So the other thing that's kind of playing into my mind here, when a person reenters the community, they have that prescription. How do they get to a pharmacy? Is the other piece that's kind of going through my mind, because they may not have transportation, they may not be affiliated with a pharmacy.
All part of the discharge planning process. I mean, that's, the
Right.
discharge planning process has to
And
take
that's on
all of
DOC.
housing and transportation and, medical, so,
DOC should be able to maybe inform us as to what currently happens. And then we can figure out where the gaps might be.
I think so, and also for those folks, I'll add that for those folks that are eligible for Medicaid to be reinstated, Medicaid does pay for non-emergency transportation, and that includes to the pharmacy. So, and that does care for some of the local, geographic challenges, although we're in a rural state. We don't have public transportation options often, but that is one of the components of the discharge planning process that should be also considered. And I think it is being considered when it's possible.
Anything else for the commissioner? Wow.
No, thank you, Commissioner. I know that we'll be seeing you in committee quite a bit this session. Look forward to it, and some of the discussion will be around this issue, but also how we might utilize Medicaid waiver or something, administrative services for what I would consider the best possible coverage for inmates. So we will be talking about that, healthcare for those who are incarcerated.
Absolutely.
Anything else? Whoops, we have a question. Copper?
Thank you. Did we say that we were gonna have WellPath come into the next meeting to talk to us about what they do in terms of that transition period?
No, we haven't.
Should we? Good idea.
Ben?
I do recall from the previous meeting that they testified that I think a lot of this is still being worked out on an operational level, but as far as the medication that they're given, I think they were talking about a 30-day period to have that, 30 days worth upon release. But my understanding is that that's still being worked out. I think that's a contract issue. But that's at least one aspect of what WellPath, if I recall correctly, is at least attempting to do.
Well, part of this thing was that WellPath was going to work to make sure that the individual had a provider as well. To follow up with the provider. So I think we should find out what they are doing or what they're not doing.
Yeah.
Yeah, and another aspect, and this is in Act 22, there was a lot of changes to sort of who a provider is and what they can do. Telehealth is now an option within that act, so that's a potential basis to expand access for someone upon reentry. So, and I believe that's in section 6B of the act. And there are other changes to, if you just couch a provider as a healthcare provider rather than the more specific physician or APRN. So I think the definition kind of broadened that definition a little bit in addition to the telehealth option.
Okay.
Can I ask Ben a question? So Ben, and I don't know if this is a you question or not, but it says in accordance with federal requirements, so the telehealth, so it doesn't, what is that? Do we know the implications of that as compared with what state law.
I'm not sure what those federal requirements are.
Yeah.
But that would definitely be another level in addition to the state regulations of telehealth providers. That's an additional thing to be aware of.
Okay, thanks.
I can tell you what those
Yeah,
are.
okay.
So let's move on here. We do, I don't know, I know we have Isaac from DOC. I don't know if you want to weigh in briefly. I don't want to put you on the spot.
Hot seat,
I
right?
don't want to put you on the spot because I
He's running
know,
over
I
to
know
the
a lot
chair.
of this is for the commissioner, but I don't know if there's anything that we've talked about that you could weigh in on or you'd rather wait for the commissioner.
I think I'll defer to the commissioner, but I will say that, this is something we think about a lot. I think it is one of the most logistically difficult yet critical pieces of our correctional system, and ensuring that folks have that continuity of care is so critical to keeping folks alive. We know that as research shows that as folks are re-entering the community within their first 2 weeks, they are 10 to up to 120 times, 29 times more likely to die of overdose. And that overdose is a leading cause of death for people re-entering communities in the United States. So it's certainly, we have a lot of work to do on this. I think we've laid a really strong foundation through Act 76, through efforts to increase access to buprenorphine in our facilities, but we also know there's a lot more work to do, particularly I think around the non-pharmacological interventions. Recovery is more than just medication. It also includes coaching, mentorship, connection to community, housing, social supports, transportation. So that's something we're really actively exploring. There's a meeting of the Opioid Settlement Advisory Committee tomorrow. I will be there. We'll be speaking with Recovery Partners of Vermont and Turning Point of Rutland. We're putting forward a proposal to expand recovery coaching in all facilities in Vermont, which is very exciting about, as Senator Ron Hinsdale said, not just, making sure that people can get to appointments at hubs, but making sure as well that we are going to them. And so we're really excited about that close collaboration with all members of Recovery Partners of Vermont, and making sure that they're able to access our facilities, meet with people while they're currently incarcerated so they can build that critical degree of trust. That's going to take funding. We're asking our community partners to take on a whole new caseload, but they are excited to do that work. So we'll have more detail on that.
So you're presenting that to the Opioid Settlement Advisory Committee tomorrow, and one of the guideline principles for the opioid settlement dollars is that it will be for systemic improvement, not ongoing operational expenses. So is that a part of your proposal? So
Yes.
it's more about what? You don't have to do that now, but I'll be very interested to see what you have there.
Topper, you still have your hand up. I'm assuming that's legacy hand. I'm going to shift Tom Dalton. Tom Dalton is here with Vermonters for Criminal Justice Reform. Why don't you?
I'm here with Jess Kirby, my coworker
Okay.
too. Is that
Why
okay
don't
if
you
we come up
both come on
together?
up?
Great.
Yeah.
Where should we sit, over here?
Yeah, why don't you grab the other chair?
Pull right up, right beside Tom there.
Yeah. Welcome.
Thank you.
So why don't Tom and Jesse just introduce yourselves for the record.
Hi, I'm Tom Dalton. I'm Executive Director of Vermonters for Criminal Justice Reform. And this is my colleague and coworker, Jess.
Jess Kirby. I am the Director of Client Services at VCJR. I also worked at Safe Recovery for about 8 years until about a year ago. And I'm a member of the Opioid Settlement Advisory Committee as a person with lived experience.
Okay, all right.
So should I just talk?
Yeah, just talk.
Okay. So first of all, thank you for having us. This is an extremely important topic. And I submitted written testimony to go along with this. It's long, it's 10 pages with more bullets than
You're not
belong.
gonna read it.
No, with more bullets that belong in any document. But I kind of just, once I got started, I wanted to get things on paper in case anybody wants to take a deep dive, or in case there's a legislator that is thinking about recommendations or legislation, maybe they can find some ideas in there. So, but I'm definitely not going to go through all of it today. Thanks to Act 176 from 2018, Vermont is the clear leader in providing full access to medication-assisted treatment in correctional facilities in the country. And I want to take the opportunity to say thank you to Representative Emmons. I know several committees were involved in that, but that particular committee took a ton of testimony and it was really complex, and I'm thrilled with the outcome. I think the bill is extremely important and has done a lot of good. A lot of people who are incarcerated struggle with opioid use disorder. I think it's accurate to say the majority. The reason I say that is because we know that 55 to 60% of people who are incarcerated currently are receiving treatment, medication treatment for opioid use disorder, and we're probably not reaching everybody. That varies a little bit depending on time and also facility to facility, but it's obviously, a gap that this bill filled, that, those people, most of them were not getting treatment prior to that. EOC's MAT or MOUD is the new term, program is one of the largest MAT programs in the state and one of the most important because it's the only entity that can fill that role for people during the time that they're incarcerated and help them with their transitions in and out. Like I said, our program, I say ours, I'm very invested in it, is the best in the country. But as you've heard, there's still room for improvement. I think it's accurate to say that we're not yet fully realizing the potential benefits to public health and public safety that we could be getting from this program, even though what we've done is pretty miraculous and is already hugely helpful. So I think that in particular, it's about treatment retention. So the two areas, I think there's been a lot of conversation about treatment retention upon release and those dangerous gaps in treatment if things aren't coordinated properly in advance. But I think something else that I would like us to be thinking about is retention during periods of incarceration, because we're hearing about a lot of people who are involuntarily discharged from treatment while they're in the facility. And that causes a lot of problems because those people still have opioid use disorder. They're still experiencing withdrawal and strong cravings. And it's actually driving the demand for non-prescribed buprenorphine. And so that drives the demand for people to try to divert buprenorphine to the people that are not receiving it. And then that's often the way that people are removed from their treatment, is because there's a suspicion or maybe, evidence that they're attempting to divert medication. So it's a big issue. I go into it in a lot more depth in the written testimony, but I just wanted to highlight it here as something to think about. And Jess, do you want to talk a little bit about what we're seeing in terms of people that are coming out of the facility and in the facility too, if you want?
Yeah, so we talk to people every day that are in the facility. We get lots and lots of calls of people who we were working with prior to becoming incarcerated, who we'll work with after and we work with during. We have over 200 clients. They're all justice involved. So like over 90% of them have spent time incarcerated. We have over 200 clients. So we're getting a lot of access and a lot of anecdotes and really hearing what's going on for people. We often hear people leave correctional facilities with prescriptions, and then we worry about things like transportation to the pharmacy. We worry about, Medicaid. We worry about all of these things. But the first issue to focus on, I think, is that not everyone even gets that prescription. And that is the goal, and it is happening. It's not that no one comes out without a prescription, but I think that the gaps of people coming out without one are common. Like, it's not just like once in a while we hear of somebody who, oh, they didn't have a prescription, I wonder what happened. It's pretty common. I mean, I went back and looked at our numbers, and since like the very end of May, so basically June, we helped 12 people that got out, and we came to us immediately and didn't have medication. So 12 people in like 5 months, that didn't have any medication. And oftentimes it is things like people maybe got released somewhat quickly, but we need a procedure for that, because there's always going to be people who aren't sentenced, who are just detained, that could get out at any court date, that could get out on bail. That's always going to exist. So we have to find a way to make sure that all of those people aren't coming out without any medication, and it happens really, really frequently. And I worked at Safe Recovery for 8 years up until recently, and there's a low barrier review program there. We have many clients who are in that, who would become incarcerated and all of a sudden would be at the door at 5 o'clock on Friday, and the provider left 10 minutes ago and they didn't have any meds and just got out. That is really common, and I'm still in a lot of touch with them, and they're still experiencing that as well, and have actually reached out to us because they know we, are a little more involved with the justice population, and just saying, hey, we want you to know we're still seeing this, and that sort of thing. So, I just wanted to say that is a common thing. That's the number one issue, is that those prescriptions aren't even happening, I think sometimes for a lot of people. And, some of the benefits to making sure that we figure out ways to fill that is that, having access to medication-assisted treatment is a really important form of rehabilitation. It's also a really important form of crime prevention. People are coming out, oftentimes there's no housing, there's no transportation, they have no supports. They're coming out in complete shambles. And if on top of that, they're now in withdrawal, don't have medication, are having severe cravings, the likelihood that they're going to turn to use is very high. And that puts people at risk for committing crimes to feed that need for opioids. And so I think like there's a lot of components to think about that. I think, it's the most importantly is deaths, and we know that making sure that these gaps don't happen cuts the overdose risk at least by half. So, but there's also other things that it could definitely benefit if we could find ways to do that.
Yep. Yeah. So I think that's true. And just for some context, maybe I should have mentioned at the beginning that VCJR, we operate a specialized recovery center for justice-involved people with substance use disorders, with a big focus on people re-entering from incarceration. And so this is something that we have a lot of experience with and that we're focused on a lot. And one of the things that we wanted to talk about, because I just want to make sure, because this program takes a lot. It takes a lot to implement. It's a big burden on the Department of Corrections staff. But it's really, really important to the success of people that are justice involved with substance use disorder. And like I like to say, when they succeed, we all benefit, because they're very high risk, but also very high impact members of our community. And so part of what we wanted to do was highlight some of the benefits of the program. Jess mentioned rehabilitation and crime prevention. And then she also mentioned cutting overdose deaths in half or more. There was actually an academic research study about Vermont's program in particular that found a 60%, over 60% reduction in overdose deaths following release incarceration in Vermont. So really big thing that we've accomplished, and improving that, there's still ability to improve that, which is what we're all talking about. So also, that study also showed improved participation in treatment following release if you were on the medication in the facility. And I think there's data that says something like, it shows that a very large percentage of people that are accessing medication-assisted treatment learned about it while they were incarcerated, got experience with it while they were incarcerated, which is really helpful. And then there's an important case finding process. So part of what was in Act 176 was that Department of Corrections will screen every single person as they come into the facility for opioid use disorder. So we're finding people that were slipping through the cracks before. And then that bill provided that you offer them the opportunity to start treatment, which prior to that bill, you could only get MAT in the facility if you were already on it before you came in. And now we know that about half of the people that are on MAT in the facility did not come in with it already. So that's a huge number of people that we're bringing into the treatment system. So that wasn't a possibility before. And so also there are fewer interruptions in treatment. And there's research that shows that medication assisted treatment is most effective when it's continuous for at least 5 years. And so any interruption reduces the effectiveness. And so allowing people to stay on their medication while they're incarcerated helps the overall outcomes. And prior to this bill, you could only stay on the medication, even if you were already on it when you came in, for 30 days. And then eventually they extended it to 6 months. But at 6 months, whether you needed it or not, they would just cut you off right then and there, which seems crazy today. But, so this is allowing people to have the opportunity to have continuous treatment, which is a huge benefit. It's preventing a lot of preventable suffering because people were coming in and going through agonizing withdrawal when those could have been avoided by starting MAT immediately. There's less contraband in the facility. There's a less illicit opioid use and improved safety and order in the facility. And I don't want to speak for the commissioner, but I think Representative Emmons, you might remember hearing him talk about this in a recent PRIN meeting where he was saying that they've seen the benefits from his perspective of this program. And so I think that there are a couple of limiting factors that are preventing us from getting the full benefit. And that is inconsistent coordination upon release, and then also interruptions in treatment while incarcerated. Both of those are leading to gaps that are very dangerous. And so in my written testimony, I provided some recommendations, 16. I'm not going to go over them all here.
Can I ask a quick question, clarification? Can I ask, you talked about being discharged from treatment while incarcerated. Why?
So the number one reason that we're seeing, correct me if you think something else, but is that it's around a focus on preventing diversion of medication. So in other words, if somebody's trying to take some of their medication that they're getting dosed with back to the unit, either for their own use later, which is actually pretty common. I can talk more about that. And I talk more about it in the, I talk a lot about why there's diversion happening in the written testimony, but a lot of people are being involuntarily discharged from treatment because of concerns around diversion. And sometimes these aren't even related to diversion of their prescribed medication. We have a situation we're working on right now. Jess is working with somebody who is being involuntarily tapered from their methadone because of an incident of smoking in their living area. Do you want to talk about that a little bit?
Also, just not following commands perfectly. They ask you to do a lot with your mouth. It's a little, I think any of us would be embarrassed to stand in front of somebody and lift your tongue, run your gum this way, run it that way, open this, it's a lot. It's pretty invasive, in your mouth, and so the person kind of did a few things and then said I take methadone, it's liquid. If I was diverting it, I wouldn't be able to speak, and refused to do some of the other commands. And then there was an issue with smoking, and now he's being involuntarily taken off his medication. And probably the highest risk person I've ever worked with, long history of overdose, and is likely to be discharged or be released soon because he is detained. And so it probably will happen unexpectedly at one of his upcoming court dates. But it's a lot of things like that.
So, forgive me if I'm paraphrasing this, but so it's, and you didn't say this, and these are my words, but it seems as though that sort of failure to comply, that your punishment is removal of your medication. Now, would we do that with any other type of medication? diabetes, if you failed to check your blood levels to see if your BAC was where it was supposed to, or whatever the term is.
I was gonna say the same thing.
I was like, this, okay, thank you. I just, and we'll hear from the department next.
You're not gonna
in a
take
couple weeks,
insulin
but-
away from
Right.
someone because they refuse to do
Because they
that.
see it as life and death, which this is as well, you know?
Yeah.
It's important to like remember that diversion as behavior is a very low risk behavior. Like it's very low risk to anyone, where taking somebody off their medication is very high risk and likely to result in death.
Yeah, I mean, I realize that there needs to be,
Yeah, there
you know,
needs
some way to address that, but
But
Taking him off a required medication doesn't seem to be the logical thing to do.
Yeah.
to me, but-
So is there, I guess I have to look at DOC for this one and maybe we'll get a response. What education, if any, do folks have within the Department of Corrections to understand the clinical necessity of treatment for folks?
Who's gonna have the education? The staff
The
or?
staff, the staff having education about the designation of substance use disorder as a medical
Medically
issue.
necessary.
It's not a superfluous use of medication. Understanding their behavioral issues with prisoners, we understand that.
yeah.
But we also understand that there needs to be some thought of caring for people, medical caring for people.
If I may, I would just note the department does not make medical decisions for people in custody.
No.
The medical contractor has full autonomy.
So
So
who makes a
decisions are-
decision about withholding
It would be up-
medication?
It would be up to the medical contractor if they're making this
So
claim.
the medical contractor is taking away the treatment? Do we know that? Is that how that's happening? I'm trying to understand
Yes,
this.
but I think a distinction to make here is that, and one of the things that I talk about in the written testimony is there's what I consider a harmful enmeshment of security staff and medical provision in this context. So in other words, when Jess is talking about following commands, that's a corrections officer that is watching somebody take their medication and then deciding, do I think that person's trying to divert some of it or something like that? And so that security staff is DOC, and they're then communicating to the medical providers about their concerns. And the thing is, there's a DR, disciplinary report process, to deal with if there's smoking in your room or something like that. That should be a separate process. It shouldn't be communicated back to your medical provider and have them have an expectation that they're supposed to, act on your medication around that when it has nothing to do with your medication. And so there is some enmeshment happening there that it's not purely happening that the medical staff is making decisions with no input or I would say pressure from the security side or the, leadership of the facility, that kind of thing. And we know from the PRIN surveys and from testimony to this committee and others from the union that there is a lot of frustration and unhappiness around this program among some staff. And that I consider it stigma-based, it's not science-based. And so I think education is one way to help address that. But I think we need to acknowledge that that's happening because patients, incarcerated patients, say that they feel that they have sometimes derogatory things said to them, that they feel that there's an effort by security staff to get them off their medication, that the goal is to get people off the medication. This is how they feel. And so I think one way to address that is to try to disentangle these two sides of it and let corrections security staff wait outside the door in case they're needed. But if you're just going to get your dose, I feel like that should happen with medical staff and that the response should be a medical response. This person that we were talking about has not heard from the provider at all, was not told by the provider, you're being tapered off your medication because of these concerns. It's just all of a sudden his dose is going down and he has no understanding of why. There's no conversation about what the concerns are, about problem solving, about behavioral health response. about prioritizing health and safety. And this is contributing to the demand because if he goes off his medication, he's going to be in withdrawal, he's going to have cravings, and he's going to seek medication on the illicit market within the facility, which is driving people to divert.
Right.
And so it's something that we really need. And one of my recommendations was, I feel like we need a work group around this. I know some people cringe about work groups, but 2 work groups led to the Act 176. And I think that this is a thing that's community and facility, that working out how to make this happen, that there's a need to have community stakeholders involved, and that we should be, maybe one idea is to recommend having some type of a working group process that can kind of work on some of these issues.
One other thing I think that would be really important that could, when we think about how do we fix some of this, I think would be really worthwhile would be, because I still think the main issue is that, like, one of the very important issues that people aren't getting that bridge script a lot of times. And yeah, sometimes they do get it and they say, I think I'm going here, call it to this pharmacy, but they don't have a place to stay and they end up here. And most people do not end up in residential programs. Most people are not going to quote unquote sober houses, recovery residences. That's very small percentage of people, but I think one thing that we could do is when people are getting out unexpectedly, those people should know, what do I do if I get out today for medication? There should be a process ahead of time that's like, hey, you're going to court. If the judge ends up letting you out, you need to immediately call this number and we're going to get you medication. Because I was speaking to a nurse at the facility today about this patient that we were talking about, and she said a lot of times what happens is people call like 2 days later when withdrawal symptoms really set in, and that if it's been over 24 hours that they can't write the script now. So so the person needs to call in that 24-hour window, and they weren't really even told to call. They're just kind of freaking out to try and figure it out. So I think one important thing that could be done probably pretty easily is making sure there's some sort of communication happening about these abrupt releases that maybe they can't 100% plan for, about what should the person do if that happens. I think that could be a somewhat simple way to try to make sure that people that are coming out are not getting no medication. So.
And we've been trying to fill that gap a little bit ourselves. Do you want to talk really briefly about our partnership with Johnson Health Center?
Yeah, we have a partnership with the Johnson Health Center, and they actually come to our office but see patients virtually. They come to our office weekly and they see patients virtually every day for us, and it kind of has sprung into care for xylazine wounds and lots of other low barrier medical care, but it started because of this exact issue of people coming to us abruptly and needing to be able to access low barrier prescription quickly. And so often we are like, a couple weeks ago on a Friday, I went to court for a client I've been working with many years. I knew was high risk. I knew was coming out without housing. I went to court and we ended up not leaving the courthouse till after 5. So we get back to my office, I'm like trying to give him clothes. He only has his correction issues closed, trying to give him snacks, like trying to help him see if he can get into a shelter. And then as he's walking out the door, there's so many things going on. I'm like, wait, do you have medication? Do you have buprenorphine? And he was like, oh my God, no. I'm like, oh my God, no, I don't. So I'm like, get back in here. So he gets back in and we call Johnson Health Center. And, it's simple, and he's been on medication in the facility, all these things. And so she was able to make sure he got a script within like 15 minutes. But if that hadn't happened, he honestly might not be here right now. That's a very reasonable thing to think could have happened. So that is common. And he could have died of an overdose, but instead I was able to call her, get a prescription, and then take him to the pharmacy myself and make sure he got it. But there's not 100 doors where you can do that. You can't knock on every door and somebody's gonna, in a minute, be able to help you access that. So, it's a pretty common issue. There's a lot of effort and there are things happening to try to make sure that doesn't happen. And that's really important to know, but just that it still does happen. And it's really important to figure out a way to address it. So I'm really glad that you all are focusing on this so much. It's really, really appreciated.
So we'll end up doing more testimony on this for December 12th meeting. To look at the reentry piece, look at what we have, and then how the Medicaid is connected. I got something
I'm thinking that we should probably have WellPath here
as well.
as well.
And the Department of Health here, the Department of Health.
I mean, all I want to say is, I don't know about you all, but I never hear this much good news about something that we've done as the legislature. So, you know, I just really appreciate you coming and telling us something we've done, particularly some of the leaders around the table, is working, and very specifically what's not. I just really thank you and applaud that. And it is great to know that, you know, we can listen to our colleagues who take all this testimony, and that you are providing this testimony and it's saving lives. Thank you so much.
I want to thank you all, but I also want to thank Annie Remnisianu, who was a big part of the legislative process, but I've been in very close contact with all through this implementation phase. And probably more than most, I have a glimpse at what it took for her to stand up this program in her role, and what it's taken for her to try to improve the program over time. It's incredible. It's incredible. And she's incredibly responsive. If we reach out to her, she gets back to us right away.
Which we do, about a lot of these different cases, we reach out to her.
Yes, she's looking at it in a big systems way. She's working with DIVA and others at, really evidence-based evaluation. And so, she's somebody that deserves a lot of credit for this success.
She's taken it from the policy to the implementation.
Yeah.
I mean, lots of discussions in our committee room about this when we were first looking at MAT and sorting out pretrial diversion issues and then transitional issues. And so working together with House committees and the administration has been, and now we're seeing the benefit of what we've done. So appreciate your being here a lot.
Can I say one last 30-second thing? It's really quick. I just meant to say it. It's 30 seconds. Is that okay? I just wanted to say quickly that a lot of people are, because we've done such a good job in the community of making sure that we have a lot of access points for medication, that we've seen some data that says like at 45 days, a very high percentage of people are accessing medication. But I just wanted to note, and I meant to do this earlier, I'm sorry, that, that means that people went and got medication. But I think we really need to look at, what does it look like at 7 days? Like, to be able to see what some numbers about what that very early period of how many people are getting a script quickly after release. Not like, did they go figure something else out later? That doesn't tell us, like that piece that I think we're all trying to figure out a little bit. So I just wanted to say that because I forgot. Thank you.
Thank you. So we're going to do a little deeper dive in this on the 12th. And one thing before I hand over to Tucker. DOC, do you have directives in place for the MAT program? Assuming you do. I'd like you to bring those next time, and I'd like to do a little deeper dive in terms of when someone is involuntarily taken off, because there is, in the law, there is a process for that. And the medical provider can involuntarily take someone off. That would be recorded in the inmate files. And the person's provider on the outside would need to be notified, but that would need to be authorized by the inmate. And if it's being done by security staff, what is the process? Also, inmates do have access to their inmate files.
Right.
And that would be interesting to figure out what is in their files, because we have put in a process for inmates to have access to their inmate files. So I'd like to do a little bit of digging with that, because there is in statute a process for the medical provider to do this. And we need to talk about this further with DOC.
Much of that information is also outlined in the health contract, so we can make sure to bring a copy of
That would be helpful, because we'd also like to connect with WellCat as well for that. Topper?
Madam Vice Chair, I had a little bit of trouble listening or hearing what you just said. So if what I'm going to say repeats it, just say, forget it, Top.
Okay, I'm sorry, Topper.
Oh, that's all right. I'm wondering why, I would like this question answered. by somebody that comes in to talk to us. Why can't we replicate what happens out in the community when the person that's incarcerated is now out in the community and they're with their medical provider? Why can't we do that in the prison so that there's a transition? It doesn't have to be the same person. It's a transition of what happens. You get this kind of counseling, etc. As you're taking buprenorphine or whatever you're taking, and then transitions right out into the community with whatever provider that WellPath person sets them up with.
Anybody want to answer this one? This one's really complicated, Trapper. It's always been our understanding that in the MAT program out in the community, there is a medical provider that is there for the person, but there isn't any counseling that occurs.
That's true of a lot of programs, yeah. Yep.
So we're modeling the MAT program in the incarcerated facility to be the same as what is in the community.
Right.
There's no counseling happening in the community MAT program. There's none happening in corrections.
The one thing I would say about that is that in the community, counseling is available.
You can at least choose.
And so in the facility, counseling is available, but you have to put in a med slip every time you want to meet with somebody. You don't know who's going to respond to that. You don't get to develop that therapeutic relationship with an individual counselor and have a set time every week that you meet with them and you're having an ongoing conversation. So I think that, in terms of parity with the community, one thing that could be done would be to allow people to have standing relationships with counselors in the facility, standing appointments, and maybe allow them to work with outside counselors through telehealth or through, programs that are willing to come into the facility. Because while the research shows that it's the medication that is cutting overdose deaths in half, not the counseling, so we don't want that to, we don't want the tail to wag the dog. Counseling is very valuable for a lot of people, and people are recovery focused. People are change focused. A lot of people are change focused while they're incarcerated. It's a period of reflection. They want something to be different the next time they come out. So I could see some value to having that. And if you allowed them to have a relationship with an outside provider through their tablet or through telehealth or something like that, they could then continue with that same person when they got out. So it's one thing that could be thought about.
Yeah.
The other thing too, we think everyone who's coming into an incarcerated setting has a relationship with a medical provider in the community, and quite often they do not.
No, yeah.
So they end up with the only medical provider sometimes they've had in their life is WellPath.
Yes, that's true.
So that's the other piece that plays into this too.
Yeah.
But let's do a deeper dive on this on December 12th and figure out who we'll have in for testimony. But we know we want the Department of Health, probably DEVA back here, DOC, and WellPath. Anything else on this one? This will be a good discussion. I'll take up the bulk of our next meeting, I would assume. Thank you.
Thank you very much for being here.
Thank you. Thanks for having us.
Documents. So another issue that's been percolating out in the public, which we've dealt with a little bit here, has been juvenile justice, and particularly providing services for folks, juveniles involved in the criminal justice system. And that sometimes gets enmeshed with the issue, with the legislation that's been put in place over the past few years about raise the age in terms of where does a particular charge start, in which court, family court or criminal court, adult court. And there's been some high-profile situations that we thought many of us may be getting questions from constituents, and then we thought it might be helpful to hear from Eric Fitzpatrick from our Ledge Council about the statute for raise the age. And before we go there, I'm going to turn it over to Senator Sears because he's the one who's really worked really hard on this legislation and also going forward here.
Well, yeah, there's three different issues going on, and I think there's a lot of confusion even among legislators. There is the when somebody can be charged as an adult who's as young as 14. That's so-called Big 12. The second thing is the raise the age, which has only gone to age 18. It did not go to 19. We've because of COVID and other reasons, we've held that off. And I think this would be the third year in a row that we put in legislation to delay the implementation. And the final one that gets absolutely confused all over the place is youthful offender status. And I was hoping that we could just better understand all three categories and how they all work together. But one of the issues that obviously has come up in terms of the so-called Big 12, I would just remind everybody that those started in the 1970s following the deaths in Winooski, Colchester. And there was a special session of the legislature which developed that law. So it's not something that should be new to anyone. There have been some changes last year when we included attempts at any of those offenses, and we upgraded some of the offenses of the Big 12 where there had been changes in the law over the last few years. But just to make clear, there's the three different categories, and I'm hopeful that Eric Fitzpatrick, who drafted the original 1970s language,
When he was a juvenile.
Oh, girl. Eric, you want to come on up on that one?
Can I say one thing about the high profile that we've been seeing on the news recently? Yeah, it is disturbing to the public to see that and not understand the conditions for charging as an adult. And it would be helpful, I think, as we're going through this, to understand that as much as possible, Eric, as we can, from your perspective, why he was charged as an adult, knowing it's Big 12, but also trying to understand with all of the information that's come out, what's going on, so. Just not so much that
Well, we need to know that.
it'll educate us, but I think it's also extremely helpful for our constituents who may be tuning in. Because this is an exciting place to be.
Right after Thanksgiving.
Yes, no,
Yeah, exactly. So Eric, welcome, and if you could identify yourself and.
Yes, thank you. Good afternoon, everybody. It's Eric Fitzpatrick with the Office of Legislative Counsel. Nice to see everybody. As you've heard from Senator Sears and from the chair and from Senator Lyons, here to talk about the Big 12 and the Raise the Age initiative. And I understand the context that you were just talking about, Senator Lyons, as well. I can't comment on the particulars of any ongoing case, but I think that what I described will provide you a pretty clear picture of what the options are in those types of cases. You know, so that the type of case where a young person commits an offense and may be charged in the criminal division, may be charged in the family division under other circumstances, but I think I can be hopefully clear enough so that it will become pretty apparent what options are available in a situation like that. So having said that, I think stepping back for a moment, so what I'm going to be trying to talk to the committee about is what happens when a young person commits an offense, right? Because that's what we're really talking about here. A young person, a minor, commits an offense that certainly would be criminal if the person was an adult. What happens in that situation? Well, a person could be treated as a juvenile in the family division of the Superior Court. A person could be treated as an adult in the criminal division of the Superior Court. And that makes a big difference, right? Because if you're in the family division, your records are going to be confidential, the proceedings are confidential, you're going to be treated by the Department of Children and Families with a treatment case plan. You're going to be under their supervision. You're not going to have collateral consequences because there won't be a conviction on your record if you successfully complete whatever the many collateral consequences there are of criminal conviction, whether it be related to housing, student loans, crossing the border, possessing firearms. It's a very long list, and those things would not apply necessarily to a person who's been treated as a juvenile in the family division because they don't have a criminal conviction. On the other hand, obviously, an adult in the criminal division, proceedings are public. People can view the records, they're public. You're under the Department of Correction supervision, not DCF. And you have a lot of collateral consequences to conviction. So, and I want to add just for a moment of background, those two options, being treated as a juvenile in the family division, being treated as an adult in the criminal division, there's a third option to that Senator Sears alluded to already, a third pathway, you might think of it as. And that third pathway is known as youthful offender status. And that's been on the books since the 90s or so. And it's kind of a mix, actually, appropriately. I'm sure Senator Sears will remember this. It was initially called a blended sentence. As I know, when it first got started, it was referred to as a blended sentence. And that's because it's kind of a blend of the juvenile and the criminal approaches. And it's a blend in the sense that the way it works is, if you qualify, if a young person who commits this offense qualifies for youthful offender treatment, they are treated in the family division as if they are a juvenile. They have a case plan from DCF, and if they complete that case plan successfully, then they get all the benefits of juvenile treatment. You know, it remains confidential. It's not open to the public. They don't have a criminal record. All those benefits accrue to that person. On the other hand, if they don't satisfy their conditions of juvenile probation, if they violate probation, they get sent back to the criminal division and they're sentenced as an adult. See, so you see how it's kind of it's almost a carrot and stick approach. You could think about it. There's a great opportunity for benefit there if the person complies with their case plan, because they get all the benefits of the juvenile treatment. On the other hand, there's a possible negative consequence. If they don't, they get sent back to the criminal division. So it's kind of a middle path, YO for short, youthful offender, blended sentence, that kind of thing.
Can I ask a quick question? So an individual who gets into the family division, juvenile court essentially, not through youthful offender, but just that's where they go under our statute.
Right.
What happens to them if they're not successful in the treatment plan with DCF? I understand with youthful offender, they go to criminal division. What about the person who's in a juvenile?
Violates the terms of their juvenile probation, for example.
Right.
Yes.
Is not successful.
I think
In family court.
Right. Yeah, I think that's generally outlined in their DCF case plan, what the consequences are going to be for failure to comply. Now, they're not going to be automatically treated as an adult in the criminal division, but the consequences are outlined in their case plan and are certainly different than in the criminal court because they're not going to be incarcerated, but it's more of a treatment approach than a criminal one. But I think it is dependent on the plan itself.
So for the youthful offender status, that would start in family court automatically?
Not necessarily.
Not necessarily.
No.
That's where it gets mushy.
Yeah.
That's great. But if it started in family court and the person's under a youthful offender status, they complied with all the requirements. At the end, the record is expunged, good to go. If they don't comply with their conditions and everything that's being asked, then it's kicked over to the criminal court.
Exactly.
And they're treated as an adult.
Right.
Is there a bottom age to that youthful offender status? Is it
The way it's set up now is that if you could have been, it's an offense that otherwise could have been filed in the criminal division. So any offense that would otherwise subject the person to the jurisdiction of the criminal court, which is, it's going to depend on, it's kind of segueing me into the next point, which is it depends on the age and the nature of the offense.
So what age are we talking about, like for the youthful offenders, that like age 10, 12, up to 18?
Up to 18 currently.
Including.
Yes, that's bringing in raise the age factor.
Right.
But under current law, yes, maximum is 18. And anyone who commits a criminal offense starting at age 14, that would otherwise, because right now, this is kind of safe, I'm going to jump ahead for a moment and pass out my sheet of because before we're talking about the Big 12, the question that often comes up is, well, what's the Big 12 anyway? So.
No, the Big,
Yeah.
there's a carve out for the Big 12.
So I really think the manslaughter is the same.
Right.
Those are the biggies.
So in response to what you're getting at, Representative Hammond, sorry, whether or not a case starts and remains in the criminal division or the family division depends on two moving parts. And these two moving parts are the age of the person and what the offense was. All right. So generally speaking, if you look at your Big 12 list that I just sent out, generally speaking, this list of offenses is what brings a case into the criminal division. All right, so if the offense is one of these Big 12, it's depending a little bit on the age, which I'll get into in a moment, but if it's one of these Big 12, that's your criminal division case. If it's a non-Big 12 offense, starts in the family division, generally speaking, right? So that's one of the primary distinguishing factors as to where the case ends up. And you'll see, as Senator Sears was alluding to too, just this past year in Act 23, there were some changes made to this list of 12. For example, in each one, you'll see that after it lists the offense, it says, or an attempt to commit that offense. Each one of those 12 says that at the very end of the line. That was added this past year in Act 23. And also, for example, a couple of aggravated offenses were added as well. You'll see those at the bottom of the list. But for the most part, it's still a 12 offense list. And if you are a young person who is age 14 and above, right now that includes through age 18, and you commit one of these offenses, then the statute provides that generally speaking, those cases start in the criminal division. So you see that may have an impact on some of the cases that you've heard about. Age 14 and above, case starts in the criminal division under this statute.
Automatic, because it's a Big 12.
Correct. However, there's another option for a person in that situation, and that is, you were asking Representative Emmons about whether a youthful offender case always starts in the family division. In one instance, it does. And what the statute provides for is for the state's attorney to do what's called a direct file, right? A direct file is to take a case that would otherwise be in the criminal division under the Big 12, right? Age 14 and up, one of these 12 offenses, that case would go to the criminal division ordinarily, right? But statute provides another option. State's attorney can direct file the case in the family division as a youthful offender proceeding. Can't direct file it as a juvenile case, because remember, we already said if it's a juvenile case, it doesn't go into the family division unless it's some other offense, not one of the 12 on this list. So that's an option. So that also would have applied in situations where the offender is age 14 to 18 and has committed one of these serious offenses.
So persons from the age of 14 to 18, it's Big 12.
Yep.
When that occurs, the state's attorney then has that decision.
Correct.
Do they do a direct file to family court?
Mm-hmm.
If they don't do that, it's automatically in the criminal court.
Yes. Now, let me add one thing to that, which is that if they choose the latter option that you just identified.
The criminal court.
Yes, they file in the criminal court.
Can they go back to family?
Yes, and the way that can happen is that if they chose not to direct file as a youthful offender proceeding in the family division, and they chose to file it in the criminal division instead, either the defense attorney or the court or the state's attorney can then file a motion in the family division to have it transferred down there for youthful offender treatment. So that's the second part of the answer to your question. Does a youthful offender proceeding always start in the family division? No, it can if it's a direct file. Or the other way a youthful offender proceeding can get to the family division is if somebody files a motion on a case that was already in the criminal division and says, no, we think this should actually be a youthful offender case. So we're going to file a motion in the family division. When that happens, case automatically gets set down to the family division and they have a hearing to decide whether it's appropriate or not for family division treatment.
So that was my question. Who's going to decide on that motion?
Yes, court, family division.
It will be.
In both instances. Actually, even in that first example that I described, the direct file, it doesn't stay there automatically. After the direct file, the family division has a hearing. And the hearing has to determine whether or not a case is appropriate for youthful offender treatment. And there's a lengthy list of what has to go into a hearing of that nature. The DCF has to do a risk assessment. The court has to make lengthy findings about whether or not it would be in the interest of public safety, whether or not the DCF has appropriate services to treat the person as a youthful offender. And then there's a long list of, the nature of the offense, was violence involved, that sort of thing, all kinds of factors that go into this decision. But it's not automatic. It requires a conclusion by the court that the case is an appropriate one for youthful offender treatment. If the court says, yes, it is, then it stays in the family division. Court says, no, it isn't. It goes to the criminal division for treatment as a criminal case. Now, one thing that's sort of, I think, interesting to bear in mind about the two different avenues that the case can get to the family division for youthful offender. Think about it. If the state's attorney direct files in the family division, right? Nothing is ever, and the court decides, hey, yeah, this is appropriate for a youthful offender case. We're going to keep it here in the family division. It was confidential from the beginning, right? Because they direct filed it in the family division. Never went to the criminal division. So everything is confidential completely about the case. On the other hand, if the case started in the criminal division, at that point, it's public. Right? So if someone afterwards says, all right, I want to file a motion to have it transferred to the family division for youthful offender treatment, yeah, when it gets there, if the family division says, yes, this is appropriate, we're going to keep it here for youthful offender treatment, yes, everything from that point forward stays confidential. But that initial filing was public. Right? So as I think you were getting at, Representative Adams, that decision point in the very beginning about where to file is very important.
And who can make the motion again? The defense counsel?
All three. Defense, the court can do it on its own motion, and the state's attorney.
And the state's attorney.
Yep, all three can make the motion.
Quick question. So I assume though that arrest records are not confidential. Is that where we are with that? I mean, it's, arrest is made.
If it was direct filed, you mean?
Yeah, if it's a direct file.
Yeah, I think the police officer's records probably would not be, right?
Right.
So that still leaves the raise the age question. Because what we're talking about now under current law is everybody, what we just described applies to everyone up through age 18. Right?
Up to and including.
Up to and including, yes, thank you. Until 2020, it was only up to and including age 17, right? So a few years ago, in fact, prior to 2020, that's the way it had always been. The age of majority for purposes of whether you end up treated as a juvenile or an adult was age 18. So 17 and below, you went to the family division. Once you turned 18, you went to the criminal division. Under the Raise the Age initiative, which has been going on for several years now, that maximum age has gradually been going up. So in 2020, it went up from 17 to 18. So from that year forward, the maximum age at which a person could end up in the juvenile division, in the family division, treated as a juvenile, was age 18. So you could commit one of a non-Big 12 offense as an 18-year-old and be treated as a juvenile in the family division instead of having to go be treated as an adult, which it had been before 2020. That was the first step of raise the age. The second step, which was raising the maximum age to 19, as Senator Sears was alluding to, that was originally scheduled to go into effect in 2022. It was going to be bumped up one more year so that if you were age 19 and you committed a non-Big 12 offense, you'd go to be treated as a juvenile in the family division. But as Senator Sears was indicating, that was in the midst of COVID. There was, I think, a lot of difficulty in implementing the services and the other structures that were going to be needed. So that was bumped out by a year to originally, actually this year, to July 1st, 2023. Then this past year, again, in the same bill, Act 23, it was bumped out another year. So now it's scheduled to go into effect in 2024, I believe, that the 19-year-olds would be effectively, their age would be raised one more year. And so they would go to the family division for non-Big 12 offenses.
So Eric, Senator Sears does have his hand up. So Senator Sears.
Well, I wanted to make sure we flagged the issue of confidentiality. And if you could check Eric on that factor, I seem to remember, and it wasn't a Big 12 offense, but in Bristol, some kids vandalized a dugout at a Little League field, and the police published their names and et cetera on Facebook. I believe they were 14 or 15 at the time. And I thought we made some changes in that. And one of those changes was that if there was a direct file, the police records were not available, or no records were available of the arrest. A direct file by the state's attorney, so that the state's attorney, if in his or her discretion, would be able to keep the case confidential. But
yes,
I may be mistaken on that. I know we did some work on it after that event in Bristol.
You might be right, Senator Sears. I might have missed it, but I will go back and look it up.
Yeah. Okay. Thank you.
Yeah.
Otherwise, you're doing a terrific job.
He's making it very clear.
Well, it's really, this is very helpful.
Oh, good.
It's a helpful reminder. I think we'll have you into Senate Judiciary in the first week to try to, when you're not in House Judiciary, to try to do that for us.
All right, I'll let the chairs work that out, but I'll be there. One thing I'll just add real quick too is that about this raise the age piece, and because it's been bumped out a couple of times, and in the same legislation that passed last year, Act 23, there's a reporting requirement that DCF report, give this committee a progress report on how they're coming with this implementation of the raise the age. It's been bumped out a couple of years, and I think Peggy posted the report on your website. So I haven't had a chance to look at it yet, so I can't profess to know what the details are, how they're saying the progress is, but I think they have generated a report, and it's there to look at.
So I hate to ask this question, but what if there's a 12-year-old that has committed a Big 12? Is that automatically in family court?
It's funny, there's a 12-year-old, I think that's the age that it begins. There is a motion process for younger kids, not younger than 12, but 12, 13-year-olds to be treated in the criminal division. So there is an ability by filing a motion. It would.
So
It starts in family though.
Correct.
It would start in family?
Yeah.
Okay, and there would be a motion to move it to criminal?
That's right.
But it does start in family?
Yeah.
I think not being on judiciary, one thing I want to make sure I understand is when it's transferred to criminal court, are they in all other ways than sentenced as an adult would be? I mean, what is the outcome of being moved to criminal court if you're 12 years old? That you're not going to be.
Or 14.
Or 14.
Or 16.
Are you like in Vermont under the age of 18, can you be placed in an adult correctional facility?
No.
Okay.
But we don't have a facility to put them in.
Right.
So by default, you do place a juvenile in one of our correctional facilities, but you need sight and sound separation. And then you've got correctional officers, supervisors that have no history of this person. I mean, that's the quandary we're in with Woodside being closed.
Right.
That's the gist. So the issue, even if a person is arrested and it starts in criminal court, it's a Big 12, it starts in criminal court, even when they're arrested, they're a detainee somewhere, and they will have been held probably at Marble Valley Correctional Facility with sight and sound separation from the incarcerated population.
Isn't that also a little bit like solitary confinement?
Could be, that's the issue. That's the issue with closing of Woodside.
Right.
That's
There could be
why,
up to 4 people in that. I believe there's 4 beds available at Rutland, so.
Marble Valley, so you could have 4 juveniles.
But Representative Emmons is correct. Right now, there used to be a memorandum of understanding between DCF and DOC that anybody under 18 who was convicted as an adult would be held at Woodside rather than in a correctional facility. And then when they turned 18, they would go over to the correction system. But that obviously without Woodside has created a quandary for the state, which is another reason why we have to get a new facility up and running as soon as possible.
And we're working on an intermediate step, but hopefully we'll be up and running.
But you're
January.
correct. It could end up, I think there was a girl who was at Marble Valley who was more or less in solitary confinement, but she did have staff with her all the time. But
If we can get the temporary juvenile facility up and running by January to March this year, that will help. And we put in $1 million in the capital bill this time for the Agency of Human Services to go out and for RFPs and start figuring out how we go forward with a permanent facility. They're out there now with BGS doing this. So we're moving ahead, but it's in the interim. Where do we place it? It's not a good solution. You can't leave them in a hotel room, and you can't leave them with DCF staff or the back seat of a police cruiser.
Do we know where, I'll ask Eric this, I don't want to open up Pandora's box, but do we know where the Supreme Court case is at this point with the Beckett facility?
I think it's.
I don't need to.
Yeah, there's still waiting to issue.
Yeah.
Arguments been made.
Okay,
Still there.
that will be our December surprise. Yeah.
I mean, I don't know if we're in discussion, and I will have to go at 3.
Our discussion.
Are we, okay. And I, not living and breathing this on judiciary, I don't exactly know what Senator Sears was referring to with Winooski and Colchester in past decades. But, I just wanted to be, go ahead, Senator Sears.
when Lewis Hamlin and
Savage.
murdered, and I can't think of her name right now.
Right. It was 14-year-old.
The 14-year-old, and
Feels like yesterday.
there was an outcry, and the Vermont legislature met in special session, and they changed the then juvenile laws because Savage was under 18 and I believe could only be held until he was 21.
Hamlin was the other.
Over 18 and was they sentenced him to 40 years. So there was an outcry about our juvenile laws, and that's when they developed the Big 12.
And Woodside ended up being a response to that in terms of facility to hold them.
Okay, well, I hope what happened in Addison County is is another punctuation mark in looking at our juvenile justice system and, where the discretion lies to.
I'm a little confused because weren't there 2 murders in Addison County?
There were 2, one is 10. So I think maybe, this wouldn't apply because they're 10. So the 14-year-old, I hope this marks a look at how far the pendulum swung in one direction and that it go back in the other direction. I just want to say that before we end. I'm sure that was a heinous, event that happened all those many years ago, but we talk all the time about how young people's brains are underdeveloped and to saddle them with I can't think of a reason to saddle them with a lifetime of loss of freedom, for a crime that they committed when they were 14. And the way this young person was treated, which feels like a further extent of the law under the discretion of the state's attorney, is going to have a scarring impact on him and his family, and caused harm to communities in Vermont.
But let's also remember that every 14-year-old is not the same as every other 14-year-old, regardless of race, ethnicity, or background. And that there are adverse childhood experiences, there are social determinants that can put in place neural pathways that commit them to behavior that are very difficult to counsel out of. So it is important that in addition to any of the punitive things that happen, that there's also supportive counseling and work that's done to make them as healthy and committed to a better life as much as possible. So, but it's not as simple as saying someone's 14 and therefore.
No, but I don't think that helped him on a path to betterment. And I don't know what's happening with the person who's done it was.
Talking about individual cases, there have been a number of high-profile cases where kids have been treated as youthful offenders who have committed some fairly serious crimes since the implementation of the youthful offender laws. And there have been cases where kids who, I'm sure that the court or the defense attorneys will probably make one of those motions to have that particular case dealt with in family court. But it's an individual decision of each state's attorney, and we give them great latitude and power. And oftentimes people don't realize there's an election for state's attorney.
Good point.
But I think the key is where it should start, because the state's attorney would have, if it had started in family court, the state's attorney wouldn't have the authority to get it transferred to criminal.
They would.
I think that needs to, they would.
They would.
They would be able to transfer it to criminal, and it's like, where should this start? And I think this is an example that suggests that we should really look at that again.
But the bigger question, do you take the discretion away from the state's attorney?
No, it's not taking discretion. It's just where is it gonna, what's the default for where it's gonna start?
Where it's going to start.
Give the state's attorney a little time to think about whether it's appropriate to move it to criminal court.
Well, the other issue there is the timing for the decision-making. When is it made? So if it has to be made immediately after the crime is committed, it might be a little more difficult than having time for any sort of discovery or information that would influence the decision. I don't know the answer to any of this.
And we're only talking about the Big 12.
Yeah, we're only talking
about the Big 12, but I think that the issue then is, well, where's the damage done? The damage is done if they start in criminal court. If it starts in family court, there's not any, there may be downsides with the victims, and that's very important. And that's part of the consideration of whether it goes to criminal court, but.
So if it starts in family court and the person is under DCF custody, where's the person housed?
You're back to the same old
Back to
problem.
the-
Until we have a new facility, there are little choices, and even
my
if they
point.
are, I mean, even if they're charged in adult or juvenile court, there are no facilities in Vermont available, and that's why at the last meeting, I recommended that we open the 4-bed facility at Marble Valley, have it available, use DCF staff if necessary, because they're already sitting in motels with some of these kids. And, you know, and one kid was sent home, and I'm not sure that was the best choice, but on a very serious crime was sent home because the court didn't find any other place to put him. So I'm not sure that's appropriate either.
Go full circle.
Right, back where you started.
We go full circle.
Yeah, it does. Until we have a facility available that's secure.
Eric, do you have anything else that you wanted to share with us? 'Cause I think we're winding down. It's like 3 o'clock and 12 o'clock. The committees just know. This is very helpful, Eric. It really helped clarify the process.
Any other questions, just let me know.
And, you know, we did this as well, just in case, you know, we get calls from constituents and.
Eric, could you just briefly, the age limit for youthful offender, just so people are aware of that?
Is the age.
I think it's maximum 22 now, if I remember correctly.
Yeah.
So you can even be a little bit older.
That gave more time for treatment, et cetera.
Right.
Does that include 22 or is it up
Yeah, I
to?
think it does include 22.
As long as we have a place.
True.
Anything else? Okay, well, this was a educational day. We learned a lot.
Well, I think you've already done the agenda for the 12th.
Yeah, it's all going to be MAT and who knows what else.
Are we coming back to this? I'm interested only if there are additional steps being taken at the Supreme Court, just an update on that, on the Beckett facility, and any additional information on a juvenile facility. Do we have?
I think we should have DCF in to give a brief presentation on their report, which is lengthy, but if we underline brief.
And the RFPs were due back in mid-November, so they may have some information. That would be good.
Last I knew, they didn't have any takers.
Oh, really?
But one of the things that Senator Brown and I were just debating back and forth is how development is taken into consideration, if it is at all. And I think DCF can answer that, or at least begin to give us information to help us understand. Yeah, but I think that's an important issue. If we can get just a little tiny bit, we don't have to have the big thing.
Since you raised Beckett, I think it's important to understand if the Supreme Court, however they end up ruling, and nobody knows, but however they end up ruling, could affect all the group homes throughout the state that house various populations. And many communities may not even be aware that some of these individuals with developmental disabilities and others are in their communities in those group homes. So it's not only just the Beckett issue, but it could impact all of those.
And it's not just those who are involved in the judiciary.
Right.
Yeah, so that might be a helpful something to hear.
DMH and DIVA.
Yes, I know. We've been embedded in that. Well, at least you and I have.
Yeah.
Yeah, okay.
So I know the forensic facility report's coming out at the 6th, and whether this.
Oh, it is?
Committee should.
The 6th?
The 6th of December is my understanding.
Did we?
Is that right? Is that?
Yeah, we're meeting tomorrow, Senator Lyons.
Yeah, we're meeting tomorrow too.
Right.
Right.
Yeah.
We're supposed to finalize the report tomorrow.
This is the last, No, it has to be before the first.
No, they got an extension. We granted an
Oh,
extension.
that's right, we got an,
Oh, we did.
Yeah.
I'll send a follow-up email, but I did have a group that wanted 15 minutes to talk about out-of-state incarceration.
Talk to the chair.
I thought we were co-chairs. No, no, no.
Well, sort of.
Okay, wait.
This time.
I wait for.
Why don't we close the meeting down?
But anyhow, I will follow up with an email on that. I don't know if there's an opportunity to extend the agenda by 15 minutes or something, but.
Follow up with.
Okay. Okay.
Anything else before we go off of YouTube?
I'm sorry, I didn't catch all of that, Senator.
Out of
You want
state,
out-of-state discussion?
they want to talk about out of state incarceration.
Okay.
So we're done for today. I want to thank everyone and thank folks who are watching us on YouTube. And we are done and we will be back on December 12th, so we can